dear audience. In the next few minutes, I would like to present my PhD work about the effect of biologicals on the risk of cardiovascular events. I'm a second-year PhD student at the Department of Dermatology in Semmelweis University, and my vision is to reduce the burden caused by comorbidities in immune-mediated inflammatory diseases in IMID. And in order to achieve that, I would like to contribute to the optimization of the therapeutic sequence, taking into consideration their effects on the comorbidities. We had two projects. In the first one, we investigated the tumor necrosis factor inhibitors' effect on the atherosclerotic cardiovascular events. So let's dive into the first project's background. As we know, the cardiovascular diseases are among the leading causes of morbidity and mortality worldwide. The major pathogenical background for it is atherosclerosis, in which an inflammatory player is the tumor necrosis factor, the TNF. This cytokine also plays a pivotal role in the IMIDs, in which diseases there is a higher risk for the development of cardiovascular diseases compared to the non-effective general populations. Biological therapies targeting this cytokine are widely used biological treatments, and they may have a potentially beneficial effect on cardiovascular comorbidities through the mentioned common inflammatory pathways. However, these therapies are generally not among the first-line therapies, most probably because of their high cost, whereas the conventional immunosuppressants like methotrexate, they are much more affordable, but they are the first-line systemic options. However, they do not directly act on the specific TNF-mediated pathways. So therefore, our aim was to investigate and compare the effect of TNF inhibitors to the conventional therapies on the atherosclerotic cardiovascular events. We used the PICO framework, and we hypothesized that TNF inhibitors can decrease the risk of atherosclerotic cardiovascular events compared to the conventionally treated groups. And after the systematic search and selection process, we got 56 eligible articles, from which 29 data could be included into our meta-analysis. I would like to show you our major result of the outcome of major adverse cardiovascular events. The overall effect size showed us an about 20% lower risk for the TNF inhibitor group for occurring MACE compared to the conventionally treated group. This was not only clinically relevant, but also statistically significant. And this was also true, as you can see, for the subgroup analysis with rheumatoid arthritis and psoriatic patients as well. As a strength, I would like to highlight that our subgroup analysis was the first which could confirm the benefit of TNF inhibitors over conventional therapies, specifically in psoriasis. However, these were non-randomized observational studies with highly heterogeneous comparator groups. However, we concluded that TNF inhibitors can decrease the risk of atherosclerotic CV events, and therefore we could recommend the first-line use of these biological treatments in order to reduce the cardiovascular burden. However, to strengthen our conclusions, we would need randomized control trials with the active comparisons of direct comparisons of active substances. I can present now happily that our paper related to this topic has been published in March in a top journal at the field of dermatology. Moving forward to the next topic, we investigated the same biological treatment group on the effect of heart failure. TNF inhibitors are generally very safe and well-tolerated treatments. However, they have some contraindications, and one of them is, interestingly, the heart failure. But what is the origin of this association between TNF inhibitors and this outcome? Basically, the FDA reported case series of new onset and worsening of heart failure in the early 2000s with the available TNF inhibitors at that time, and since then the therapeutic guidelines contraindicate their use in milder and more severe heart failure cases. However, the literature is highly controversial about it, encouraging us to systematically review and analyze the available data on this topic. we created a PICO framework. We compared TNF inhibitor-treated groups to non-TNF inhibitor exposed patients, and we measured the occurrence of heart failure separately, the new onset and worsening cases as well, and we hypothesized that TNF inhibitors do not increase the risk of heart failure. After the systematic search and selection process, this time we got 53 eligible articles, and 50's data could be included this time. Initially, I would like to show you the result of new onset of heart failure, including patients from observational real-world studies. The overall effect showed no statistically significant tendency either towards the increased or decreased risk of de novo heart failure, and this non-significant neutral effect could be seen also for worsening of heart failure when we included only patients with pre-existing heart failure diagnosis. And we also could collect and analyze data from RCTs. And interestingly, and it's really important that we could see almost the same effect size for randomized patients as for the same outcome in the observational studies. As a strength, I would like to highlight the high number of patients we could include, and because we almost could 300,000 patients included into this meta-analysis. And I would like to also emphasize the rigorous filtering of outcomes into our analysis to ensure the highest possible quality of our analysis. However, we had no data from IMID patients, from RCTs, on worsening of heart failure, and the definitions were not standardized. However, based on our findings, we can conclude that TNF inhibitors had no effect on the occurrence of heart failure, and in case strengthening our conclusions by randomized control trials and future registered data, even more IMID patients could have a benefit from these highly effective anti-inflammatory therapies. We are now at the manuscript writing phase, at the end of this phase, and our target journal, this time the European Heart Journal. I would like to give you just a short summary or key message from our two projects. In the first one, we clearly observed the beneficial effect of TNF inhibitors, and also in the second one, we couldn't observe any harm of TNF inhibitors, and we totally can agree with the authors of this commentary we received this month to our publications, that large-scale pragmatic randomized control trials are needed to be sure finally that TNF inhibitors are friends or foe. So this is the summary of our two projects, and this is the additional activities connected to CTM. I would like to thank you, the program, and also my supervisors, the continued help. And now I would like to thank you for your attention. I'm eager to hear your questions if there is any. I was a bit quick, as I can see.
I mean, both were in the bottom of my heart. Of course, this is our major research area also, and I'm very happy that you actually addressed two very important questions, even if you are shy and you forgot to mention. The first part, of course, is very, very important to understand the oral surveillance study of JAK inhibitors versus TNF-alpha, because we felt that TNF-alpha inhibitors are just too good, and not that JAK inhibitors are very bad. So if you have any time in your future, just try to repeat this and compare it with JAK inhibitors, and then you answer this question. But this first part definitely told us that the TNF-alpha inhibitors are very, very safe. They are not causing MACE, and so it might be that they are even better than JAK inhibitors, so the difference we found was actually due to the fact that TNF inhibitors are better than the other one. The second part, of course, is a long-time story. The thing that TNF inhibitors cause heart failure comes from two Swedish patients who were drunk, and both of them and they unfortunately died of That was like 20 years ago, and since then nobody actually repeated this. So we always felt that this is not true. And you very nicely pointed out that new onset heart failure and somebody who already has heart failure are two different things. And of course, you also listed a lot of papers. I think the Fred Wolfe was the first who showed that actually after infarction, actually TNF-alpha inhibitors reduce the risk of heart failure. So in the second part, I just want to have one question. Did you have any studies on the clinical response of to the TNF inhibitors? Because in the cardiovascular field, it seems that the cardiovascular benefit of the TNF inhibitors is related to their clinical response. So in responders versus non-responders, whenever kind of patient is that, would it be different? Do you think, did it come up in your analysis, or is it possible that after this you can analyze what is the difference between clinical responders and non-responders?
Thank you for your question. That is really important. We couldn't do that because of the limitations of the included studies. They didn't report, I think, or just a few studies reported that thing that the patients had any response to the, or how is the level of response. So I think we couldn't do that, but maybe in the future we can do that in a clinical trial or in some other designs. But based on the included studies, we couldn't do this comparison, I think. But it would be a good thing to
Professor
measure
Goulet.
it.
Thank you, and congratulations. I think both of these were very, very important and perhaps practice-changing articles, or will be, hopefully, in the future, the second one. And my question is related to this. In the introduction, it was mentioned that the whole idea is basically to analyze scientifically the available data and then return that to the patient bedside. Now, when we are introducing TNF inhibitors to the patients, we must send them to cardiologists. Yeah. We have to control them regularly. Cardiologist has to contribute to the treatment. My question is, based on your research, then you basically would not recommend that in the future. Is it true? And the second is, how would you then implement this? How would you then change the practice, what we are now doing?
Thank you for your questions. I think this is one of the important things about the second project. That's a hard question because I know the limitations of our analysis, and we didn't have enough data, I think, in the worsening cases of heart failure, because we only had 4 studies where we could include patients with already pre-existing heart failure. And this is not so, the statistical power of it is a bit limited. So based on just our results, I wouldn't recommend the negotiation or avoiding the cardiovascular track before the TNF inhibitors. However, in case if we would have more data, for example, from other larger prospective registers, and we would have more safety data from longer follow-up times of TNF inhibitors, and our conclusions were strengthened by them, I would also recommend that it can be an unnecessary investigation for the patients. However, based now, currently, I wouldn't recommend it. And what was your second question? Sorry. How is it changed?
The question was basically, if you would recommend, how would you actually manage this? But
it's involved a bit.
First of all, I really enjoyed it, and I would have enjoyed it even more if you were a bit slower.
Yes.
1 minute slower during the first part. But anyway, congratulations, especially for the D1 publication. Now, regarding your second project, your introduction was excellent. I was missing one little thing, because you indicated that from the guideline or recommendation in NIHA
Yes.
2, 1 and 2.
1 and 2 and 3 and 4.
Not really,
Yes.
but in 3 and 4 it is absolutely contraindicated.
Yes.
Now, you didn't give us the degree of recommendation and the level of evidence supporting, because you are now tackling a very, very sensitive issue here. So can you remember what is the recommendation behind that statement?
Actually, I don't know, and I'm not sure that it's included in the therapeutic guidelines, so not in the patient's guidelines for the...
Yeah, but this is a very strong statement.
It's a strong statement. I couldn't remember if, but it's very important. Yes, I will
because
look after
I mean,
this.
tackling a 1A
Yes.
recommendation, it's very tricky. But if it is 2B, or 1B or 1C, then it must be done. And your study is an excellent example that we should really tackle recommendations or guidelines with poor, or not poor, but low level of evidence-based recommendations. So congratulations again. That was only a comment.
It's my time now to congratulate you and your supervisors, of course, for these excellent works. But we're here not only to congratulate, also to make some criticism. So the first paper is published, so everything's okay, but I would not include etanercept in the group, because as you very well know, all the other molecules are TNF inhibitors. Etanercept is a TNF receptor inhibitor, and this may have some differences in its effectiveness and side effects, as we already know in several diseases. But again, it's published, it's finished. Now, regarding the two issues, I fully agree that TNF inhibitors have a protective effect on cardiovascular events regarding atherosclerosis. There is a small Vivli publication from my group showing that, and you confirm it with larger data, and I think this is clear. And you probably know that there are other biologics that have negative effects in the first 12 weeks, like...
Yes. There are some publications about the novel therapies like the interleukin-23 inhibitors.
Exactly, interleukin-23, interleukin-12, and one drug is retracted even, although the company said, no, it's not true what you published. After 2 months, they retracted the drug because the data were very clear. So, despite the fact that TNF inhibitors are old, we don't need to try to use novel ones if we know, especially in these patients, that they have a problem, that the 12 first weeks are very critical. Now, regarding the second work that we are going to do, the cardiovascular failure, I'm not a cardiologist, despite the fact that I congratulate you that these studies come from dermatology, but I have a little bit bad feeling, because you know that the heart failure has to do a little bit with chronic and recurrent infections. And TNFs have this problem of silent infections. It does not need to be always tuberculosis, but we have silent infections because we don't have symptomatology. And maybe this could be an issue on the chronic long-term evaluation of heart failure if silent infections induced by the fact that the patient gets long-term TNFs play a role. The answer is not given yet, but take it into consideration in your work. Look if there is any data in patients with heart failure, if you find any, if they had recurrent infections or other type of infections after the diagnosis of heart failure. This could help a little bit to understand if this will be shown, what is going on.
What you mentioned in one of the first plot that you have a high heterogeneity.
Yes.
And why you said it? How was it assessed?
So yes, we measured the heterogeneity with actually 3 different methods. As you can see, the first is below also the subgroup analysis, and also we can see for the overall analysis as well at the bottom of the forest plot. Yep. So one method for conducting the I-square test, which is the first one. From the I-square test, we can actually know the percentage of the between variances about the included studies. We also have the tau square test, which is the second in the list. As you can see, this gives us the absolute amount of heterogeneity, and we can also conduct statistical hypothesis testing, and this is the result of it is the PYU at the end of the list, and based on these methods we can judge the heterogeneity. As you can see in the subgroup analysis, for example, of psoriatic patients, the I-square test was resulted in 0%, so we assume that these patient groups were close to each other and the heterogeneity was very low. However, we can see that in the rheumatoid arthritis patients, for example, the heterogeneity was higher. I would say that between, so this 60% about, and this is a moderate level heterogeneity.
Yes, it's
it
very
can
good
cause
word between. Let's not see the confidence interval.
yeah, I know.
It's
This
sad
is a
about it.
limitation. Yes. We didn't know.
And here in this plot, I can see that there is a test for subgroup differences. That was for comparison for all subgroup or only for the first two?
Only for the first two, I think, comparing the rheumatoid arthritis and psoriatic patients. So where actually subgroup analysis could have conducted.
I also have a question to this for us,
Yes.
basically, because you concluded, and the editorial for your paper possibly also suggested that we need an RCT on TNF inhibitors, right?
Yes.
And I'm surprised because your data is very strong, very solid. So why do we need an RCT after such a robust meta-analysis? Were these studies underpowered or low quality from the methodological point of view? So why is it not, could you not do a futility analysis or something, right?
Thank you. It's a good question.
And neither of you
this is because the
have shown...
confounders, I think. So it's,
Yes. So this is it. I was missing the risk of bias and the
yes,
grade.
it's too crowded. But
Yeah.
I downgraded very strictly the risk of bias assessment because there were so many confounder factors, both in the rheumatoid arthritis and psoriatic groups. So this is the highest limitation, I think. It seems that our data are robust, and they are. However, we should be aware of the limitations, and the confounders are the highest limitations, I think, because these patients, they had several comorbidities as well, so they could have diabetes, hypertension as well, so it can be confounded for the outcome as well.
What would you do differently if you were to design an RCT on that?
Yes, that's a good question. I would. Yes,
So you're relieved. You don't have to answer.
okay.
But that's a very...
The problem is when you get a criticism in a paper, you always have to write limitations. And the usual thing that they ask you to write is it has to be an future RCT study. Now the question is, who is going to do this? Who is going to pay for that? Nobody is interested, practically, from the industry. This would never happen. So usually when I get this, I write, is it possible? Who is going to pay? And then they say, okay, don't write it as a limitation, because the reality is just to write a limitation that never will be realized, it's no reason. I think your data are very robust to claim clearly what is going on and don't use limitations that someone is saying, there is a limitation, we don't take it as granted, because such papers have to be included in the guidelines. I mean, this is actually the reason why we publish, to have such robust data to use them in guidelines. Otherwise, we have to teach the people who do not do it every day what to do in the everyday treatment. TNFs, now they become less expensive, but not any more attractive for the industry because they go to induce new drugs. However, we know if you compared with methotrexate, we know methotrexate reduces inflammation, does not inhibit the mutilation, ongoing mutilation. There are data showing that TNFs do both, anti-inflammatory and inhibit mutilation. They have the genuine problem of silent infections. Yes, okay, we know this is the risk. What would you propose for treatment, primary treatment of psoriasis, of psoriatic arthritis, and now, of course, of hidradenitis suppurativa? Are you going to say primary treatment should be a TNF inhibitor? Just think about it, because there is no registration of TNFs as primaries. They have always to have another classical treatment which will be unsuccessful, blah, blah, blah.
I'm not an expert of any field of these, but I would say that I would take into consideration the patient itself, if he or she has what kind of comorbidities they have, and the prior therapy. So when we consider the first-line therapy, I wouldn't recommend for everyone the TNF inhibitors as a first-line treatment, I think, based on our result. But if the patient has more comorbidities, major cardiovascular risk factors, diabetes, hypertension, family history of cardiovascular events, which is also a major risk factor, I would recommend the first-line use of TNF inhibitors.
So you would say you would propose MTX as more safe than TNF inhibitors? Okay, you don't have this experience. I stop it, don't answer. Read it about that, because this is another big issue. What we propose to the patient. The patient says yes when we propose them. Of course, the patient decides, but who proposes? I think there is we have to change a little bit the thinking, and also for guidelines to take into consideration both your evidence and the other existing evidence, and don't keep us on the long term with all theories. But we have an expert here.
No, just because you said that Embrel shouldn't be involved, the only hard endpoint trial is the ANTRACT, where you have tocilizumab versus etanercept. So actually there is only one trial with etanercept, which shows you that TNF blockers are actually preventing myocardial infarction. And the question is that, of course, they tried methotrexate in the general population, in the Mayo Clinic and Ritka, but it was negative. But there are signs that methotrexate can actually be preventative in an inflammatory setting. But the question is that TNF-alpha is much, much better. So the answer to the question is that yes, methotrexate can prevent cardiovascular, but TNF-alpha does it much, much better. So if you have a high-risk situation for cardiovascular risk, then TNF-alpha is a good choice. And even if, I think the price is getting very close, right? Some of the companies promise that. Yeah, I mean, it will never get to the oral methotrexate, but the parenteral methotrexate versus the biosimilar adalimumab is now not so much different. And I think there will be a time when this biosimilar methotrexate will go down even more. So I think, because everybody says that, can we skip methotrexate and just start with TNF? And this is only a financial issue. Yes. Because methotrexate, TNF-alpha is always superior to methotrexate. So if I were, I had lots of money, I would definitely skip methotrexate in some cases.